Sorry, Esther Chu from Brown. I'm perseverating on one point of something you said, Patricia, and that was such an amazing talk. We were sitting here just talking about your speaking style, which is just
really fast.
It's really amazing. But the piece about the screening patients in the hallway, I was a resident under Ed Bernstein, and one of my very vivid memories is, Brent or Ludi standing in the hallway and delivering intervention. It's just the reality for so many of our ERs is that those hallway beds are such a big proportion of who we see. So I just wondered if there could be an exchange between you two or any of you, about what to do with those hallway patients and how to sort of be consistent.
I'm stepping on my sister here.
Carrie,
it used to be in our old ED, we had these rooms that were 6-patient rooms, and the new compliance stuff, so we don't have those anymore. And darn it, I always felt like when I was in one of those 6-patient rooms, and I was delivering an intervention to that one patient, I was really giving it to about 12 people with the visitors and everything else. You'd hear people behind the other curtain go, "See, I told you you drank too much. Listen to what she's saying."
I think, so while I say it's partially a hesitation about privacy, I think the reality is when they have 25 hallway beds on top of their normal patients, it's probably reality about workload. But we do have a chair area for vertical treatment, and we have signs about privacy concerns. We don't have signs in every place in the hallway because every day we make a new one, and so our compliance officers are fairly strict.
I'm not going to step on you. You say something.
Oh, you want me to say something? I'm glad I did it.
Oh, we did it in the audience.
We have to be a team, right? And so if you have a team of all the folks trained and ready to do this, if a resident can do it, a nurse can do it, a health educator can do it, then just do it when you can do it, because things move so quickly. You're in the middle of a conversation, and all of a sudden the trauma bell goes off, and you have to run to the trauma room. You might as well take advantage of the opportunity. In our emergency department, I guess things have changed, Astro, because now we have glassed-in rooms for everybody, except on the B side. I want to make a comment, though, about this contradiction between public health and clinical care. If you think about one of the quality indicators now we have is medication reconciliation. So you can think about that. Why don't we have an idea of what pain medicines they're on, what mental health medicines they're on, and what substance abuse medicines they are? It's a huge safety issue. So it should be a no-brainer for our institutions to try to solve this. In the annals, they have an editorial about the behavioral health data and the electronic record. I think we have an opportunity now to make some changes in this, because we can't give good care. If they're going to ding us, they might as well give us a fighting chance. And we're operating from from the seat of our pants most of the time. The other comment I had, I think that this effort that we're doing we're just at the beginning stages of really being. You always think that, like with cholesterol and those folks in Stanford that did all this heart health, it took them 30 years to institute it and get it into the practice of medicine, but they had a drug company behind it. And when you look at Lipitor and you see the data, it says you have to treat 100 people to get one heart attack saved. We're not subjected to the same standard. We have to show one-to-one. Or in the emergency room, you can't make any mistakes while a great baseball player is batting one in 300 or something like that. So I think that we have to look at our work in a different way. So in our study among cocaine and heroin users, it would take 20 people to show one abstinence. So, and that was independent of the fact that everybody had the same opportunity to go to treatment. Like 39% of the 1,000 people we studied had a chance to be in treatment, and they went through a detox. So in a way, I was feeling very depressed when I saw the numbers. It was statistically significant, but I was depressed. But when you look at the bigger picture of what's being, what is evidence-based medicine, and if Lipitor is evidence-based, they give Lipitor every day for these folks. We gave it for 20 minutes. So I think we have to have some perspective on the fact that we're doing a hell of a job if we even have a chance to talk to our patients about this. It's a hell of a difference than what we've been doing in the past, where we say, "Oh, you're drinking? Just stop drinking and go to detox, or get your life together." I mean, as Chris said, that's not the spirit of respect that we owe our patients. That they're not bad people. I find every day that behind the drug and alcohol, if we just think in those terms, there's a human being out there that really has a life. And when I say, "Well, why don't you go to detox?" He says, "Well, who wants to go to detox? I don't want to sit around and talk about this stuff." And when you find out about what he does every day, he's got a life. So I think we want to, start from that premise. Sorry.
Hi, thank you all for your talks. This has been an amazing session. My name is Christina. I'm from the University of North Carolina. And I had a question if you could speak to billing issues. I know that's a major barrier for us, and you've talked about it some in your talks, but for example, is it covered everywhere? What portion of it is covered? The brief intervention, the screening, both? How would you go about helping it become billable in your department, and does CMS cover it, if you happen to know?
Well, there are two
Sorry, a
levels
lot
of
of
codes, and I
questions.
think,
Yeah.
I think Carrie will go into her depth on it, but you have the Medicare codes, the G codes, the H codes for Medicaid, and you have the CPT codes. And those were put in place about 5 years ago. The CPT codes, I mean, the Medicare codes only pay for physicians to do this, or someone at the highest level. Medicaid is only turned on by states when they want to turn it on, and you're seeing what they're doing now with Medicaid turned on for the Affordable Care Act. So it's really state by state. And we have an economic crisis. And then the CPT codes are physician billing. So we've been billing through the facility fee. We've been trying to bundle our services and look at the intensity and coordination of care and using the evaluation and management of outpatient codes and raising them from one level to the next. So that's the strategy we've used. The problem with that is people getting paid a bundled amount. Like you might get it. They're going to try to give you like $300 for a visit that might be a heart attack on one hand and a laceration on the other. So I don't think that's going to work. I don't know if that's the Medicare formula right now, to just give a lump sum. So we might not be able to really bill for that strategy.
Well, it's a quagmire. I wish I could answer it. I mean, we've had, half-day sessions even in our state to try and figure out the billing between Medicare and Medicaid and the different payers and who's paying and who isn't, and if they're dotting the I, and the facility side we use that as well. But as Ed alluded to, when you get the facility side of it, which is easier to bill a little bit, that you don't really get information back from the insurance companies about what part of that they covered versus the CPT codes with the professional fee. You do get records back whether they covered what service for what physician. So it's a little bit easier to really track to see if it's happening or not happening. But believe me, you could go to a whole-day seminar and walk out with your head spinning. So I don't think there's an easy answer to that. But there is some information that you can probably find online that helps to delineate exactly what Ed was talking about the different CPT codes and H codes.
And those codes pay for 15-minute and 30-minute intervals. And sometimes you don't have that time to give. You might get 12 minutes or 5 minutes, but you're still putting a lot into it. But if you have a team approach where someone's putting in a screening and they're using a validated screening instrument, which they require, which is the DAS, the audit, the CRAFT, the CAGE, which we put into our medical electronic record, and your record has to reflect that you've done something in order to bill. So that we've passed our coders and our paymaster, to get through that labyrinth in order to bill, but we haven't really been able to see exactly this impact the bills to say this is what SBIRT has done for the hospital.
The 15-minute, the timed billing codes have been a huge barrier to implementing billing, I think, nationwide. And because you can't, to say you spend 15 minutes talking to a patient about substance use with a straight-face test, unless your providers say, oh, it's a team-based and the nurse did a little and this person did a little, is tough. But I can tell you that is recognized that there's the national big SBIRT, hospital SBIRT, and they are talking to Medicare about revamping those codes so that maybe there would be a lesser charge for less time, but more realistic to the amount of time that we would be able to spend with patients. I mean, and this is my passion, right? But if I spend 5 minutes with a patient talking about it, that's about all I'll be able to do, truthfully, without a health educator or a nurse or something else built into the system. So
we costed out our intervention with a randomized trial for cocaine and heroin users. It was $64 for the intervention, and they're only paying $30. So even what they estimate is the cost, the real cost is higher than what they're giving us. So I think the argument is that we won't be able to pay salaries with the reimbursement scale they have right now. It's true. So you can't really. I guess you have to start off with a business plan, and part of it is the money, and the other part is the value-added service or the community benefits, and then this new billing system, which may be the quality incentives for pay for performance. So we have to think, have what we call a variable or diversified portfolio when we go into this.
Unless anyone else has any other questions, I want to thank you guys. This was a really great end to the day. The four of you gave a nice summary of kind of how to take the evidence that we know and put it into practice. I want to urge all of you to please stay in touch. If you have questions, concerns, want access to some of the materials that we talked about today, it will be up on the ASAP website. It will eventually also be up on the NIDA website if and when the government ever reopens. But you can also feel free to email me, or I'm going to volunteer Andy, or Katya. My email is megan_ranney@brown.edu. You can Google me or whatever. But I'm happy to share stuff. Our goal in doing this was to disseminate and to create new partnerships. And I consider this to be just the beginning of the discussion. The other thing I am going to put in a quick plug, if you have people that you think would be interested in hearing more about this who couldn't be here today, we are giving a knowledge translation workshop tomorrow as part of regular ASAP. It's going to be much shorter than this. It's a 2-hour workshop. We're going to be discussing the basics of how to implement SBIRT in the emergency department. So encourage your staff or kind of your colleagues to come to that if they're interested. And with that, I want to really thank all of our presenters for being here today. I just can't thank you enough for your time. I want to thank all of you for participating, and most of all to thank Katya, Cynthia, and the folks from CDC who couldn't make it for organizing this.
Oh,
and
thank
Cynthia,
you.
yes, please fill out your evals. Again, yellow forms. Please fill them out and turn them in.
And we want to thank you, too.
Thank you.
Megan.